I don't know whether I'm audible and visible. Okay. Happy evening, everyone. I think you all can see me and hear me, yes? All right. So happy evening, everyone. I hope and I believe all of you are doing well. And you've given the test as well, the F3 test, F3 with N3 series that we have. F3 is Friday fast 5 MCQs. So we are going to discuss some, the applied concepts, how the basic concepts can be tested as clinical questions. That is what we saw in the recent NEET PG as well. And that's what we are seeing in all the exams, right? So like I always say, developing this MCQ skills is very, very important. And that's what we are trying to do that together. Okay. So all these tests are uploaded on the Medsynapse app. As you can see, Medsynapse by Dr. Nikita, that's the app. In that, on the home page, you have a tile called test series. In that, you will find this test F3 and 3. So this is the second test that we are having. We have it every Friday. This is the second test, right? Last Friday, we had one. And this is the second that we are doing. So I hope all of you enjoyed giving the test with the simple concepts that were tested in a clinical manner, in a twisted manner, right? So starting with the discussion here, Sonal, because we already have so many other MCQ solving sessions going on in app live, so do not want to do that over bombardment, and that is why we are just doing like 555, right? So that not to give an overdose. Otherwise, we are having a lot of KBMDs, the live MCQ discussions, and the INICET November test and discussion series also going on in app, right? Okay. So let's start with the discussion, guys. So which of the following type of sensory information is compromised by lesion of the structure at site X? So if you see here, this is the site X which is labeled here. Hai. So this is the X here. Basically, this is cerebellum that you can see here. Can anybody tell me what is this structure here? Anatomy? What do you think? What is this going to be? What is this anatomically? This is the fourth ventricle in between pons and cerebellum. Pons in the front and cerebellum behind, right? So this is cerebellum here. This is the anterior lobe of cerebellum. So cerebellum lesion basically will lead to the loss of sensation of which sensation? So remember, it is not pain sensation. It is not 2-point discrimination. You rule out the options at least. You know that with cerebellum, the proprioception is very, very important, right? Cerebellum is important for maintaining the balance and then proprioception as well. So that is why we do that joint wala test, okay? So remember that pain sensation is carried by SPT, that is spinothalamic tract. P stands for pain. Spinothalamic, remember SPT carries the pain and the temperature. PT is pain and temperature, and it's crude touch. 2-point discrimination, this is carried by the dorsal column, okay, which carries the dorsal column. Now remember that proprioception is carried by the spinocerebellar tract and also by the dorsal column. When is the dorsal column affected? Tell me one condition where dorsal column is affected, guys. What vitamin deficiency affects the dorsal column? It is vitamin B12 deficiency, SACD. Subacute combined degeneration affects the dorsal column, very, very important, and that is why vibration proprioception that goes off, okay? So remember that even that carries the proprioception. Now what is the difference between this unconscious proprioception and conscious proprioception? So tell me that which one carries the conscious proprioception? Is it the dorsal column or is it the spinocerebellar tract? Which is conscious and which is unconscious? Yes, very good, Pani Malar. Even the syphilis, tabes dorsalis, affects the dorsal columns. Even syphilis affects the dorsal columns, right? Yeah, so tell me here, which is the conscious proprioception and which is the unconscious proprioception? Dorsal is conscious. Okay, very good. So how do you remember this is? Remember that the dorsal columns The dorsal columns, where do they end? Is in the cortex, the cerebral cortex, right? The parietal lobe, which has the sensory cortex. So it is ending in the cortex, and whatever is cortical, it is conscious. Okay, whatever is cortical, it is conscious. While unconscious proprioception, the one which is ending in the cerebellum, it is not going to the cortex, that is unconscious proprioception. And since here the question is about the cerebellum, and that is why the answer is going to be unconscious proprioception is what is going to be affected. Remember, the cerebellum wala is unconscious, जो cortex में जा रहा है वो conscious. Okay, cortical functions are conscious functions. Okay, so an important reminder for everybody who's there on the Medsynapse app, there's a detailed video about cerebellum in the main videos. Physiology में, anatomy में दिखेगा, extra topics में, the surplus topics, वहाँ से you have to watch this cerebellum वाला video, very important, where we have discussed the cerebellar peduncles, the tracts, and also the various cells in the cerebellum, right? My personal garden, molecular, Purkinje, and the granular layer, and the various cells that you have, which is the excitatory cell in the cerebellum and which is the only output. All of that is what you should know. So since I have mentioned that, let us quickly discuss that. Which is the only output cell from the cerebellum? Which is the only output cell from the cerebellum? There's only one cell which is the output cell. Which one is that? Which gives the output from the cerebellum. So remember, what pukes out from the cerebellum is Purkinje. Purkinje pukes out. Okay, Purkinje pukes out. And remember, ININ, it is inhibitory signals that Purkinje pukes out. And this Purkinje pukes out inhibitory signals to where? Is it to the thalamus, to the cerebral cortex, to the cerebellar deep nuclei, to the midbrain? Where is it puking out? It is doing it to the cerebellar deep nuclei. It pukes out the output to the cerebellar deep nuclei. Okay, so this is important. And another question, which is the only excitatory cell in the cerebellum? Which is the only excitatory? Remember our mnemonics, we have learned so many mnemonics, in that are granny, the old age granny, right? Like who's like Budapa I but Josh na jai kinds, who's always excited. So remember, granny is excited always. So it is the granule cell which is the excitatory cell. Granny excites everybody else in the cerebellum, right? So remember, it is granny. Okay, so granule cell, it's not granulosa, the granule. Okay, the granulosa cell tumor में हमारा inhibin आता है marker. This is the granule cell which is excitatory. ठीक है? So all these tricks I've discussed in that video in the app. You should definitely watch that and make notes of all the videos and the tricks that you are learning. Okay, so that you can revise it later. So this is the first question. The answer here is unconscious proprioception. Going on to the next question now. Tell me, what do you think will be the answer to this one? What are you seeing here? So another very important topic, which is the Vigor's diagram. I call it the scary diagram in physiology, but I hope it's not any more scary to the Medsynapse subscribers. So what is the question? The most frequently encountered mechanism underlying this disorder is which of the following? What are the options? Amyloid, calcification, cystic medial necrosis, pericardial effusion. And this is a 75-year-old man, decreased exercise tolerance, syncopal with exertion, is all of this is given. So especially when you have an elderly patient with dyspnea, right, shortness of breath and syncope, you should always think of which valvular condition, guys? Elderly patient with dyspnea and with syncope, what valvular condition do you think of? Age-related aortic stenosis, right? Because there is age-related calcification which occurs. Okay, so there is repetitive microtrauma happening to the aortic valve throughout life, and then over a period of time, the chronic inflammation leads to fibrosis, calcification, and leading to narrowing. It is aortic stenosis. So does this prove aortic stenosis? The diagram, look at this. This is showing that this is the left ventricle wala pressure and this is the aortic pressure. Now normally the aorta and the left pressure tracings are very close to each other. What you can see here, that this LV pressure is very high than the aortic pressure. So the LV pressure is surpassing the aortic pressure, telling you that it has to overcome the aortic pressure. So much it has to contract that it has to overcome the aortic pressure, telling you again, proving that it is aortic stenosis. Okay, again proving that this is aortic stenosis. So remember, LV pressure, more than aortic pressure is suggestive of aortic stenosis, and the most common finding that we said with aortic stenosis is calcification, right? Age related calcification. Okay, amyloid deposition, amyloidosis causes restrictive cardiomyopathy. Cystic medial necrosis is associated with connective tissue disorders like Marfan's and Ehlers-Danlos, right? So this is going to be your answer here. Okay, this is aortic stenosis calcification. Next question, if I ask you, tell me what kind of murmur is aortic stenosis? You should not make a mistake in that. Aortic stenosis. Yes. Is it systolic or diastolic? Panimalar, it is not diastolic. It's think very logically. When the aorta is stenosed, anything which is stenosed, which is narrow, it will cause a murmur when the blood is flowing across it. Through the aortic valve, the blood flows during the systole when the ventricle is contracting. So it is going to be systolic and not diastolic if you think about the concept. Similarly, mitral stenosis, through the mitral valve, the blood is going during the diastole when the ventricle is getting filled. So it's a diastolic murmur. So mitral stenosis is diastolic, and this is your ejection systolic murmur during the ejection. Very good. The crescendo, decrescendo. So my next question is, will you hear it between S1 and S2 or between S2 and S1? Since it is a systolic murmur, will you hear it between S1, S2 or S2 and S1? Remember, between S1 and S2. Okay, it is S1 and S2 because S2 से diastole start होता है. Remember, S2 is di. So it is between S1 and S2. Very good, Shravya. I remember that. MS Dhoni wala mnemonic, which helps you to remember the type of murmur, right? Which was Mrs. MS Dhoni hard ass, right? That was a mnemonic. So those who know, they know this mnemonic, and you'll never forget the murmurs there. Okay? Done. So everybody is clear with this. This is basically your aortic stenosis, ejection systolic murmur. And tell me, where is the auscultation for the aortic stenosis murmur? Right side, left side. What is the auscultation area for the aortic stenosis? Aortic area is, where do you have the aortic area? Another trick, all people enjoy the money, right? That is how we have discussed. All people enjoy the money. So only the aortic area is in the right second intercostal space. Okay, the right second intercostal space. So that is where you have the aortic area which is present. And what kind of waveform, the pulse waveform do you get? Because of aortic stenosis, the slow rise which is there, it is pulsus parvus tardus waveform. Okay, the slow rising waveform that you get, right? That is pulsus parvus tardus waveform. Okay. So that was the second question, guys. Going on to the next one. This is something we had discussed in the recent microbiology PYQ based KBMD that we had conducted yesterday and today in app. वहाँ पे भी हमने discuss किया था. What do you think is the answer here? So whenever you have lengthy clinical questions, always try to read the last line first. The most likely cause of this patient's reaction is a genetic deficiency in which of the following, right? And you can see that something related to transfusion is mentioned here. So you can make a guess that transfusion reaction पूछ रहे हैं is due to deficiency of which of the following? Very good. It is the IgA deficiency. Okay, IgA deficiency, as the patients are predisposed to the transfusion reactions, especially when you transfuse the plasma, right? The donor plasma contains the immunoglobulins, right? It will contain immunoglobulin A. For a patient who is deficient in IgA, the IgA which is coming from the donor, it's like a foreign protein, right? And it will start attacking, and that is why it's going to be transfusion reactions. Okay. So remember, IgA deficiency presents with transfusion reactions. So this is what is given. 69-year-old man, hepatic disease, increased prothrombin time. Our last F3 test question. Increased prothrombin time is hepatocyte dysfunction. Scheduled to undergo operation, receives transfusion of fresh frozen plasma again, and he develops chills after that, dyspnea, vomiting and diarrhea. So this is IgA deficiency. Okay, remember, this is IgA deficiency. Clear with everyone? C3 deficiency, C3 which is an opsonin encapsulated organisms का infection होता है. Interferon gamma is related to granuloma. So the granuloma wali conditions like TB, that is what we will see here. Interleukin 2, right, very very important for T cell function, like the deficiency of which can lead to SCID like condition. So remember it is it's basically your interleukin 2 wala T cells के लिए important है, SCID हो सकता है. When the T cells are deficient, remember indirectly the B cell function will also be affected, because helper T cells help the B cells in forming the antibodies. Yes, Sonal, absolutely right. So you remember the question also where we discussed this. IgA deficiency is transfusion reaction. So this is a proof that how every sentence, every word we discuss in our classes, it's a potential question. Okay, it's a potential question. So you should pay attention to every line that we speak. Okay. Going on to the next one. Okay, tell me, what do you think is the answer to this? A similar topic that again we have discussed in the microbiology KBMD. Similar topic that we have discussed there. Tell me, what is that? So this is a one step, like a two-step question. Very good. Tell me, what is the answer? Very correct, Sharma ji. Right, and all of you have answered it correctly. So what is the major clue that is given here? Okay, so there's fever and cough, chest x-ray में infiltrate है, and you can see the tuberculate macroconidia are seen at culture. So remember this tuberculate appearance जिसका ऐसे irregular surface होता है. TB जैसा कौन सा fungal infection होता है? It is histoplasma. Remember, it is basically similar to TB, affects the chest. So in the chest x-ray, you see the infiltrates, you see the calcified lymph nodes, target calcification. All this is seen with histoplasma, which is very similar to TB. And histoplasma हमने discuss किया था microbiology KBMD में कि bat वाला history, caves वाला history. So basically the bat or the bird droppings is the exposure to that. It is, we get this histoplasmosis via inhalation. ठीक है? So remember, this is bird droppings or it is bat, the caves wala. So this is, the answer is histoplasmosis. Oh, I see that. So this is what you have this, and this is the NEET PG 24 first shift wala question. If histoplasmosis was second shift, this was the first shift. Desert sandstorm. Desert wala is what fungal infection? Desert wala is what fungal infection? Remember, desert में कौन सा animal रहता है? Desert में, remember, it is camel, and C for C, it is coccidioidomycosis. It is coccidioidomycosis. So this is called as desert rheumatism. Okay, desert rheumatism is the term for coccidioidomycosis. When I say rheumatism, remember rheumatic conditions affect the joints. So remember, coccidioidomycosis will have joint pains. Okay. Insect bite, vector borne नहीं है, ये moldy है. This is basically for hypersensitivity pneumonitis, is the moldy hay. Okay, and for histoplasmosis, remember it is histo hides in the macrophages. That is another clue given, and it is also called Oyo disease, common in Oyo region. Okay, Oyo's disease. Then you have hides in macrophages, right, similar to TB, tuberculate macroconidia, and bird or bat droppings. And specifically when you have the question mentioning the pigeon droppings, then you have to think of cryptococcosis. Okay, remember pigeon droppings is cryptococcosis, जिसके लिए हम use करते हैं India ink stain. Okay, India ink stain is used because Cryptococcus is a capsulated yeast form. Okay, it's a negative stain for the capsule. So capsulated yeast is Cryptococcus. Okay, that is Cryptococcus. Very good. It is also called Darling's disease. Right? So remember it as histo. You know how do you call your darling? Hi darling. Okay, so it's like hi darling. So histoplasma is Darling's disease. Coccidioido C is camel desert, so it is desert rheumatism is coccidioidomycosis, and pigeon droppings wala is cryptococcosis, which is the subcutaneous mycosis that we saw in the today's microbiology KBMD. कौन से थॉर्न प्रिक से हो सकते हैं? History of thorn prick. There are two conditions. It's not just sporotrichosis. You have chromoblastomycosis also. The difference is chromoblastomycosis. क्या बताया था difference? Chromoblastomycosis is going to have verrucous lesions and sporotrichosis will be along the lymphatics linear fashion में nodulo-ulcerative lesions. Okay. So remember the subcutaneous you have is chromoblastomycosis, sporotrichosis, pheohyphomycosis which has the dark melanin jesa pigment. Okay. So that is what we had discussed there. Going on to the next question. Very good. So you guys remember that. Amazing. Going on to the next question, the last question that we have here. Now there were two questions related to this in your NEET PG 24 exam in the morning shift. 6-week-old male infant, persistent discharge from a swollen umbilical stem. The discharge contains intestinal fluid. So to which of the following part of the GIT is the fistula connected? Right? So it is telling you that umbilical stem है और उसमें से discharge हो रहा है and it is intestinal. So it is, what are they talking about? What is the diagnosis here in this condition? What is the diagnosis here? Very good. This is Meckel's diverticulum, which can form the fistula also. Remember, Meckel's diverticulum is the remnant, it's a persistent vitello-intestinal duct. Okay, the vitello-intestinal duct, it can form a communication with the umbilicus and form a fistula. And you know that Meckel's diverticulum is related to ileum, right? 2 feet proximal to the IC junction, it is 2 inches tall, is Meckel's diverticulum. So it is the ileum is going to be the answer here. And remember, if from the umbilicus they are giving you the history of the urine discharge, right? Then in that case, what is the diagnosis? यहाँ पे Meckel's है, ठीक है, because it is intestinal content coming out. But when it is a urine coming out, then it is, yes, the urine coming out, it is the urachus. Okay, that connects the urinary bladder to the umbilicus, that is the urachus. Okay, the persistent or the patent urachus, in that case, it's going to be urachus. Okay, so this is Meckel's diverticulum. Ileum, remember the rule of 2. Meckel's is a true diverticulum present on the anti-mesenteric border, right? It's an important cause of intersusception in children as well. It can act as a leading point for intersusception and very, very important for Meckel's diagnosis. What test do we use for diagnosing Meckel's? What nuclear scan is it? What nuclear scan is it for Meckel's diagnosis? Yes? It is technetium-99 bound to what? Technetium-99 is a radioisotope. Technetium-99 pertechnate. Okay, technetium-99 kaun sa? Okay, Pani Millar, which one? Remember, Mec is tech. It is pertechnate. Technetium-99 pertechnate scan. Why do we use pertechnate? Because pertechnate is a substance which is taken up by the stomach mucosa. Meckel's has ectopic gastric mucosa. Even this is a question asked. It has rule of 2. 2 ectopic tissues, that is gastric and pancreatic. So the ectopic gastric tissue in Meckel's will pick up this pertechnate and you'll be able to localize the ectopic gastric and hence the Meckel's in the RIF, right? So this is picked up by the ectopic gastric tissue and that is why we use this pertechnate scan. Okay, we use this pertechnate scan. Mec is tech, absolutely. Meckel's, Mec is tech. So remember, it is pertechnate scan. So remember that in Meckel's, where you do not have ectopic gastric, the pertechnate scan can be negative also. It is not like always 100% positive in all the Meckel's. And remember, Meckel's complication, it can lead to bleeding, right? It can lead to bleeding as well. So this is about Meckel's. Remember, from the umbilicus, intestinal discharge is Meckel's, vitello-intestinal duct, persistent. Okay, so those were about the fast 5 questions today, guys, and this is the timetable that is ongoing on the Medsynapse app. So we have one timetable for the FMG December 24 and NEET PG 25 students, and we have also started with INICET November 24 test and discussion. So the students are following this timetable for the daily targets. So for anybody who wants a timetable, you can use this timetable to complete your targets for INICET till 15th October. For those who are doing FMG or NEET PG, you can complete the 19 subjects till 10th of November. We have started this timetable from 15th August. Okay, and this we have started from 31st August itself. So in the INICET TND, we have total of 10 tests where we have 1, 2, 3, 4 mini GTs of 50 questions each, alternate Sundays, and every Tuesday we have a test. Okay, there are 6 tests every Tuesday of 3 subjects each. We are done with one test, that is dermat, physio and anesthesia. You have the next test upcoming, the next 3 subjects, micro, psychiatry, pharmac on 17 September, and each test is discussed via the live class. Similarly, we have completed microbiology ka KBMD. We are doing the live MCQ solving of the PYQs in the live class. So we are done till microbiology. We are going to do psychiatry tomorrow. Okay, psychiatry is going to happen tomorrow at 1 p.m. So finish off psychiatry and then we will have medicine test coming up here. And here you will have these 3 tests and then you will have the mini GT coming up, right? So till your November, we are going to focus a lot on developing your MCQ skills. Once you finish watching the sure shot, the binge videos from the app and the rapid revision from the primary platform, then we build up. You will find the video, the episode 1 and the PDF, and similarly you will find the PDF attached there as well, along with the video. With every video, I'll be attaching the PDF in app so that it's easy for you to access the video and the app later on as well. Okay. Thank you. Mini GT1 ka discussion, mostly we will do it on 18th or 19th. Okay, 18th or 19th, we will do the mini GT discussion either in 2 parts, 18th and 19th, part 1, part 2, or together on either of those days. I'll update about that, don't worry. Okay, so we are going to do the mini GT discussion on 18th or 19th. All right. Thank you so much everyone for joining in, and please keep giving this test that happen. This is F3, that is Friday Fast 5, where you learn a lot of skills and you learn how to apply the theory. Very, very important for everybody, irrespective you are FMG, NEET PG or INICET student. Okay. Thank you so much. Goodbye. Take care and keep studying, keep revising, keep Medsynapsing and keep winning. Thank you.